We're discussing osteogenesis imperfecta. Now we're going to talk about some clinical manifestations. OI is an inherited disease of collagen 1, which causes a decrease in bone, severe osteopenia, and renders the remaining bone quite brittle, with a heightened tendency to fracture. In addition, OI is frequently associated with blue sclerae, dental abnormalities, and progressive hearing loss. The most common form, autosomal dominant inherited type 1, can be associated with normal or near normal and longevity. Other forms of OI may be lethal, for example type 2, or moderately severe, type 3. Type 2 is lethal in utero or shortly after birth because bones are so fragile that massive injuries occur in utero or during delivery. Skeletal manifestations of type 1 can severely limit physical activity. On the one hand, to being so mild that individuals are not restricted in their activities. Intermediate clinical presentations between these two extremes are quite frequent. Osteopenia is the hallmark of OI, and when it occurs in childhood, it should immediately suggest OI as part of the differential diagnosis. Ocular manifestations are famous for the presence of blue sclerae, but in some patients the color may be normal or only faintly blue. It is believed the blue color arises from the thin collagen layer permitting the underlying choroid layer to influence the color of the sclerae. Abnormal dentition or dentinogenesis imperfecta is also found in many patients manifesting as moderate discoloration to gross abnormalities because of the deficiency of dentin, which depends on a type 1 collagen scaffold. Affected teeth are amber or blue-gray. Nevertheless, some patients have normal appearing teeth. Hearing loss usually begins in the teenage years and is present in greater than 50% of patients older than 30 years. The middle ear can be maldeveloped, insufficiently ossified, or show persistent cartilage in areas that should have become ossified. Okay, let's go on to talk about the diagnosis. Typically, a diagnosis of OI can be made when multiple factors are found in association with blue sclerae, abnormal dentition, or family history. In the differential diagnosis, especially in childhood, battered child syndrome must be excluded, as should nutritional deficiencies, hypophosphatasia, and malignancies. In the battered child syndrome, there should be evidence of bruising of skin, while in OI they should be absent. X-rays or DEXA scan usually demonstrate decreased bone density in OI, while the density is usually normal in battering. In the past, dermal biopsy and analysis of collagen was performed to make the definitive diagnosis, but this has been supplanted by sequencing genomic DNA. Of course, such tests must be performed in a laboratory that has extensive experience with such testing. And continue on with treatment. Many patients with type 1 OI are able to enjoy a near normal quality of life pursuing a career despite the skeletal deformities. Fortunately, fracture frequency tends to decrease after puberty, perhaps reflecting hormonal changes. But as with postmenopausal osteoporosis, there is a second peak of fractures after menopause in female patients with OI. Biphosphonates, usually used widely in osteoporosis, appear to offer promise for conserving bone mass in patients with OI. Studies are ongoing to determine their effect and how long they can be used. And finally, a comment on the patients with osteogenesis imperfecta. The women in our case presentation developed hearing loss before any evidence of overt bone involvement, which did not become manifest until about 18 years later. In retrospect, the optometrist might have wondered about the color of her sclerae, and the dentist might have questioned the cause of her tooth discoloration, since she did not smoke. Her deafness with an abnormal CT in the middle ear should have raised red flags as well. This case underscores a problem with fragmented care, in which no one is responsible for integrated care, causing a diagnosis to be missed for many years. Fortunately, this patient is not unusual in having been free of clinical bone involvement for almost 30 years. In fact, she went to college and works as a computer programmer. She has been placed on biphosphonate therapy and visits the multidisciplinary clinic every 6 months to assess her progress.